this exciting roundtable. Just quoting a letter that the One Health Commission addressed to the White House in June of this year, which stated, without a keen awareness of the interconnectedness of human, animal, plant, and environmental health, our current systems are ineffective and unsustainable, unable to prevent illness and protect our health, even with specialized treatments for disease and metabolic conditions. This was kind of written to the White House to try to garner more support for pushing health initiatives. So this afternoon, we're privileged to host three speakers whose work, I would say, has exemplified that awareness, right? Extending the domains of infectious disease inquiry and developing new critical approaches to the most pressing of today's global health problems. So this roundtable, which is titled The One Health Agenda, an Emerging Global Health Paradigm, concludes, as Hannah was saying, the first of a two-day workshop examining, I think, set as a social scientific contribution to zoonotic and vector-borne diseases, research and intervention, and how to think about these things. And this morning, which was incredibly stimulating and productive, really kicked us off with a series of interesting papers, which have, among other things, explored the role of social scientific methods, ethnography, anthropology, and illuminating not only the interactions between animals, hosts, vectors, reservoirs, but also possibly complicating kind of commonplace notions and understandings of disease transmission and how we might think differently and think together about these things or not. So our hope is that this roundtable will broaden our discussion to critically reflect on current emphases of global health funding, institutions, kind of directions of global health, and the opportunities and challenges for interdisciplinary collaboration in pursuing this kind of integrated vision of human, animal, and environmental health and what that takes and where the blind spots are, what is the future of this agenda and how it's working or not. So with the help of our distinguished speakers and hopefully with the audience for our discussion, we just want to begin to outline also, what is the future of One Health? Has this, what might be common or orientating directions for global health interventions or modes of research. So I'm just going to briefly introduce our discussants. Begin with Professor Susan Welburn. Professor Susan Welburn is the chair of Medical and Veterinary Molecular Epidemiology Department, the director of the Global Health Academy, and the vice principal for global access at the University of Edinburgh. Decades of work on human sleeping sickness and zoonotic trypanosomiasis, have to come out all over. In domestic and wild animal populations has yielded a research agenda of impressive breadth. Sue has made critical advances in key areas of disease prevention and response, from the design and use of molecular tools to the integrated control of transmission. At Edinburgh, she has been leading a series of highly dynamic research initiatives encompassing diverse natural and social scientific expertise and linking finely grained fieldwork in Sub-Saharan Africa to laboratory-based dissection of problems at a kind of genetic level. Member of expert advisory of the World Health Organization's panels on drug for neglected disease. She's been a longtime advocate for research into neglected diseases and coordinated a number of One Health programs in Africa, such as Stamp Out Sleeping Sickness and this European Commission-funded project Integrated Control of Neglected Zoonoses in Africa. So it's an honor to have her here today. I'm going to move to the end. Dr. Rashid Ansumana is the research director of Mercy Hospital Research Laboratory in Bo, Sierra Leone. Rashid's research spans a really impressive number of fields, from disease ecology and microbiology, epidemiology, and community-based interventions in disease control. Rashid has conducted research on a diverse range of public health problems, from vector-borne diseases such as malaria, lymphatic filariasis, and chikungunya, to zoonotic diseases such as Lassa fever and, of course, more recently, Ebola. He's published critical work on both innovative and classic public health interventions, including rapid diagnostics, mobile phone surveillance, systems of water control, systems of water quality, and rodent control. So it's a real privilege to be able to draw upon Rashid's extensive laboratory and practice-based experience of grappling with and implementing global health interventions in endemic areas. And finally, it is my pleasure to introduce Durham's own Steve Lindsay, who, among other things, is a professor here in the School of Biological and Biomedical Sciences. While he has considerable expertise across a range of disciplines from parasitology, ecology, clinical epidemiology, and I might add a natural penchant for anthropology, he is a pioneer of the dynamic field of public health entomology, which has explored key vector-borne diseases, including malaria, lymphatic filariasis, dengue, and trachoma, but also with an eye to the complexities and pragmatic realities of global health research and interventions. A key focus of Steve's work, for instance, has been the design of simple and community-based tools for vector control, from household screening and larval control to hygienic pit latrines, and the impact, I mean, very nice paper about river washing on the efficacy of bed nets. So again, kind of grappling with the multiple dimensionality of these problems. He acts as a regular consultant to the World Health Organization as a co-chair on Rollback Malaria's workstream on housing and malaria, and a real champion of unlikely collaborations and new ways of approaching intractable public health problems. So again, it is a real honor to have these three to begin to speak to us, and I'm going to ask the speakers for about 15 minutes, 20 minutes to kind of talk through their experiences of One Health and what it means to them in their work, possibilities and challenges, and then might open it up just for questions from the audience. I have a couple, and we'll move them from there. So, thank you. So, would you like to kick us off?
Thanks very much. Right. It's always a Okay, thank you very much. It's a great pleasure to be here today to talk to you about this work. So I've called this talk an emerging architecture for One Health. What I'm mostly going to be talking about is the application of One Health to the neglected zoonoses, which is the diseases that I've spent most of my career working on. And I think what I'd like to start with really is this very nice image of a very Mad Max-looking virus here. And our human experience really of infection, I think, is shaped by fear. And certainly the rise of One Health in the last sort of decade has been on the back of really fear of infection and fear of pandemics. I was in Hong Kong recently, and all over the South China Morning Post, there's this sort of it's like paranoia or fear of infection, a fear of avian flu coming through, and then this man died after contracting the virus in mainland China. So in Hong Kong, you've got this dynamic of mainland China being blamed essentially for a lot of the avian flu infection that comes. And this fear of contagion really resulted in One Health becoming or getting on the agenda of FAO and WHO and OIE. And really from this 2009 pandemic, which was predicted to have caused at least 500,000 deaths. And out of this avian possible pandemic came this global response to avian influenza, this grey, which really adopted this One Health paradigm as its sort of centrepiece really for the campaign and for the fundraising. So it's interesting what he's saying about, again, approaching the American government about One Health, because this was a real government investment from the States for the grey. CDC were involved, and the American government were intimately involved with the fundraising and the donations to do that. So this was the first real international large-scale health drive based on this pandemic preparedness, and they raised $5 billion in a fairly short amount of time to implement surveillance and control globally for detection of a disease which was cost at least $10 billion for the economy and resulted in 200 million birds being killed. And the reason really, I suppose, for this fear was fear that it actually would go everywhere, fear that we were all going to be exposed to this. So we've got the first evidence in Hong Kong in 1997, right through to current infection in Djibouti, China, Egypt, Indonesia, Cambodia, Vietnam. But we actually have to be realistic about these numbers. I mean, we've had in total, according to WHO, 844 cases, well, even given under reporting, it's not an enormous number of cases, and 449 deaths. And I think the jury's still out on how much the Grey actually did, and this big One Health pandemic preparedness initiative did contribute to that. I mean, certainly it was good in prevention. And then we also have this sort of slight paranoia or fear of science. From a scientist's perspective, of course, I can't understand why people are particularly frightened of science, but there are an awful lot of people out there that do find genetic engineering and interfering with the genomes of organisms particularly frightening. And I particularly like this Daily Mail article, which was, "Are we mad to have let a maverick scientist create a virus that could wipe out 400 million people?" It's a genuine headline. And this poor professor here had created this new strain of 2009 H1N1 swine flu, selected it for resistance. And of course, the community is out on whether this is valuable scientific research or exceedingly dangerous. And I particularly like this comment from one of his colleagues. Everything he did before was dangerous, but this is even madder. So it's always very nice to have the support of your community in your research. And then, of course, we've had in the last 12 months, we've had this sort of drastic action needed on Ebola, one of the world's most deadly diseases. And of course, you know, the dogma goes, one human infected bat contact is generated at this time over 7,000 deaths now, from about 14,000 confirmed cases across 4 countries. So, you know, these are frightening events. And I was quite pleased earlier today to hear about our known knowns and our unknown knowns, because that's the crux of One Health today, is that according to Louise Taylor's work, 1,400 species of human pathogens, 60% of which are zoonotic. 80% of these new infections are supposed to be zoonotic. They're mostly viruses, which is good for the virus hunters. And in a way, virus hunting's become the new butterfly hunting of this century. You know, people used to go and catch butterflies and pin them. Now we go out and have predict, get the American government to invest 100 million in a virus hunting program in all the nastiest places in the world. Got spillovers, outbreaks, epidemics, pandemics, and endemic scenarios. And if we can't understand these terms and what these really mean in the context of infectious disease, most people on this planet would really have trouble grappling with some of these. But if we break it down into what our known knowns and our unknown knowns, you know, do we know our enemy? Well, mostly we don't. We need to know what the disease is, where did it come from, what's it in, how much of it's out there. What can we do? Drugs, vaccine, education. Nobody likes to invest in education programs, but for most infectious diseases, strong education and community programs can have an enormous impact in the absence of any drug or vaccine. Capacity, who's going to do it? Who's going to do the job? And cost, of course, how much money is needed and who's going to pay for this. And our only known is this key parameter here, this R0, which we need to get under 1, this basic reproductive rate of the organism. We know that if we get that under 1, we've got the disease on the hop. And this was, of course, all we heard really with Ebola for a long time. But our response really should lie in our relationship with our environment, and this is where One Health can come in. And I particularly like this quote, which was from the Grey: "Everything you say in advance of a pandemic is alarmist. Anything you do after is considered inadequate." And certainly, you know, we heard a lot of that recently. So could we got any One Health lessons from some of these old endemic diseases, which have been knocking around, been living cheek by jowl with the diseases for over 100 years? And these diseases are the diseases, they're quite boring, they're endemic, they're around all of the time. We have spillouts or outbreaks of them, but they're not very sexy or exciting. And of course they don't receive the lion's share of any budget to deal with them, despite the fact that they do impact on a large number of people on the planet. And again, when we have a look at the impacts of these diseases, in terms of numbers of deaths, rabies actually causes an awful lot of death every year, as does leash, hatch, Chagas and JE. And when we look at the diseases for which a lot of investment goes into, or that we hear a lot about, these diseases actually don't tend to cause a lot of death. Now, my favourite disease of all time, sleeping sickness. It's a very old disease, and first evidence of this disease was at the turn of the last century before last, when we had a devastating epidemic in Uganda. And they estimate at this time about 300,000 people died. And when the Sleeping Sickness Commission went out to Uganda to have a look about to what was going on, because there was complete panic, of course, because the workforce that was going to develop this new nation and reap the benefits and bring them back home were all dying, they would go to the lakes in Lake Victoria and come back and say, well, everybody was dead. So, I mean, it was actually the pandemic of its time. It was the avian flu of its time, and of course it elicited the response that we had with the grey at its time. Everything was thrown at this. People were sent out to deal with this problem, both in West Africa and East Africa, because the colonial systems couldn't take this. It was devastating. It's an underreported disease. This is a postcard that was sent home, so it was so noteworthy. People were sending postcards home at the time. You certainly wouldn't wish you were there. It was a burial of a sleeping sickness patient. But actually the scene was set for control of this disease that we're still having problems with now, over 100 years ago. Within quite a short order, they'd got to grips with quite a lot of our unknown knowns. They'd identified the agent. They suspected that there were two forms of the disease. They'd identified the tsetse flies, the vector. They knew the infection could pass between animals and humans, but they didn't really have any tools to control the disease. And the only thing that Robert Koch was even there, trying out arsenic-based compounds. And the only thing that they could do was introduce a policy of evacuation, take the people away from the tsetse flies and put them in camps where, of course, they died. But that was a sensible strategy at that time, to remove the infected people. And the problem with this disease today, and this is some work from one of my PhD students, a medic who was looking at human cases, mapping human cases to villages. All the little black spots are villages, and this is what happens when the disease becomes introduced into a new district. And basically the disease just goes right through the district. So it's very frightening. It really spreads through, and it causes a lot of fear and superstition in the village. So the disease has been moving very rapidly over the last sort of 20 years, and we had a start of a public health crisis when it started moving at about a rate of a district a year. And this is in places where these districts can't cope with sleeping sickness moving into them. They can hardly cope anyway with the public health matters in Uganda here. And the big problem for us was, this is the Gambiense epidemic up towards the South Sudan. And if these two diseases merge, then we won't be able to identify the disease, because we use different tools for identification of both of these different forms of sleeping sickness, and your treatments are completely different. So it would be a complete nightmare. Everything would break down if these two things mixed. But this was very strange, because while this disease was moving at this phenomenal rate, like Yannick Lancien here was employed by the French deployed in Uganda to sort of run an enormous EU program deploying these tsetse traps everywhere, and it was very effective. There were tsetse traps everywhere. And medical teams, mostly run by the University of Liverpool, were screening vast numbers of suspected cases and treating them. So it was odd that the disease was moving, and I think this is a sort of what you call a breakdown of One Health, because we had the vector biologists being very busy and we had the medics being very busy, but they completely forgot about the animal reservoir, despite knowing that there was a significant animal reservoir of infection. And we knew very well that these animals were infected because Peter Durrant and colleagues had been drawing blood from animals and injecting them into human volunteers. So we knew very well that these were very good reservoirs for infection. But at the time we didn't have any tools, we didn't have any way of differentiating the parasites which were infectious only to animals and the ones that were infectious to humans, until this SRA gene was discovered and applied in an epidemiological context. And this is just a modified coat protein on top of the modified VSG on top of these parasites, which is an indicator, a marker. So you can actually now tell how much human infection you've got in your domestic reservoir. And so I went back into the villages very early on in the outbreak in the 1990s, and about 40% of the animals in that village were carrying this human infective parasite. So we've got an enormous reservoir of infection in these animals, which was fueling this. After these big epidemics that they had, the government of Uganda, off its own bat, before One Health was sexy or popular, actually did decide to pull everybody together for monthly meetings about the state of the nation, the state of sleeping sickness. And this coordinating office for trypanosomiasis was established, which actually is probably one of the first One Health bodies ever to be established for infectious disease, zoonotic diseases. The problem with a One Health body like this is it all means very well, but if it doesn't actually have any financial or policy-making abilities, then it becomes a talk shop. And soon after the last epidemic, they were given money to mobilise. So now this organisation manages all affairs to do with animal and human sleeping sickness in the country, which means that you can actually start to think about how you can control this disease. So what are our known knowns? Well, we know that the parasites moved into cows. We know that cattle are the main reservoir for infection, but they don't get the disease, so they're silent reservoirs of infection. They never get treated because they're healthy. This same agent kills exotic animals, so if you try and improve your upgrading of stock, then those animals will get sleeping sickness and they will have CNS involvement and die. So you can't upgrade your stock. If you treat an animal, these parasites are weakened, so they can't get back in as easy as the others can. We know that if you treat, from modelling, if you treat 85% of the cattle population, you can eliminate these parasites. We know that they're cheap, and we know that making cattle targets for tsetse flies by just putting insecticide on the belly and the legs of the animal, you can prevent that animal getting reinfected. Targeting interventions in cattle is 1,000th of the cost of treating people and trapping flies, but we've got 2.5 million animals that need to be treated, which is a phenomenal number of cows. So where are we now? Well, the disease is right up here. I'm screening at the moment up in the north with COP2, and here we've collected samples from here, but this is where we have the new massive outbreak of infection in cattle, and that will be followed probably in 2 years' time if we don't get in there and treat these animals with infection in man. So everything's a panic. We know that we can do this, and we can also, if we treat these animals and put insecticide on the animals as targets, then this will have an impact on tick-borne diseases, so there are some productivity benefits. So it's quite a nice One Health application. But what about social science? Well, this was a cartoon in the New Vision newspaper when the disease had moved into Cabo Verde. And a guy's coming into the village, back of the boda with his briefcase to do some business, and this woman's being very disparaging. Hey pilot, we safe? You're new in this village, that pilot is bewitched. It says sleeping sickness is Capramida, however residents are ignorant of the disease because of their traditions and superstitions. So, there's a big job to do here with the community, which nobody is actually addressing. And actually, from a public health perspective, in Kampala, people are just considered ignorant in the village. So, there's a huge job there for us to do. In terms of societal impacts, patients have to spend 6 weeks in a HAT treatment centre if they get HAT, some of them 8 weeks. This is from a nurse. Having one HAT patient is like having 10 malaria patients. They need so much care. It's expensive for us and the patient. And the cost of having somebody in your family with trypanosomiasis was at nigh on $120 odd in terms of indirect medical costs and loss of time working from this disease. And these communities can't afford that type of cost. And I think the worrying part of this work is this part, which is directly impacts on WHO and our data. That patients that have been diagnosed from the clinic and go home, when you follow up those patients and interview them, half of them were dead. So nobody's following up the treatment, and nobody wants to hear that message either. It's not a message when you've had a lot of money from the Gates Foundation that anybody wants to hear. So just very quickly for rabies. Same for rabies. We know what we need to do with rabies. We need to actually treat a lot of dogs. These canine mass vaccination campaigns are very effective. We've got blueprint for rabies prevention and control. The Alliance for Rabies Control is looking at getting rid of rabies globally. They're setting a target for 2030 to do this. But we need to treat 70% of the dogs every year for, they say 5 years, I say probably 7 to be on the safe side. And of course, these programs end up going to the dogs because they're trying to, along with the vaccination campaign, you actually have to do something about stray dogs. And the elephant in the room is, of course, that you do have to do something about the stray dogs, and nobody wants to invest in dog sterilisation because it's just too expensive. And this is from the last month, where Kerala, the governor of Kerala, has decided to go and poison dogs with strychnine, and of course it's caused an enormous uproar. But then Kerala's got an enormous problem with rabies and dog bites. So Kerala dog culling, God's own country, must be a paradise for animals too. State-sponsored killing of dogs in India after rabies attacks. There is no excuse for animal abuse. So I think this is another area where One Health can help. And I think, if nothing else, One Health can actually bridge this gap between scientific innovation and community perception and public perception of what needs to be done in order to achieve this safe space, especially from emerging and endemic infection. So that's a whistle-stop tour. Thank you very much.
Rashid? Yeah, fantastic.
It was a really feisty thing. He wasn't having any of it.
Good afternoon, everyone. I'm sorry I don't have a PowerPoint to present. I only have talking points. I'm Rashid Ansumana from Njala University. I've been introduced. But as a scientist, I'm very much a mixed breed, having a little bit of few things. And my PhD has been tropical medicine. My thesis was on non-malaria pathogen surveillance using tiered laboratory analysis method in Sierra Leone. Now to One Health. You know, as Dr. Rudolf Virchow said in the 19th century, and I quote, "Between animal and human medicine, there are no dividing lines, nor should there be." This was posited by Rudolf Virchow in the 19th century. But you know, even though such insights existed as early as the 19th century, medical science did not crystallize this until recently, just like we are playing catch up with Ebola virus. So we have seen more emerging diseases recently than in previous times, and about 75% of emerging pathogens are from animals. Emerging diseases have hotspots where there seems to be more human-animal interaction coupled with rapid environmental changes. And incidentally, my continent where I come from, Africa, is one of those hotspots and is effectively the new front line for infectious diseases. So we that work there recognize the fact that we are at the front line. It's like you have a war, you know, and you have these soldiers going to the war front to fight. We are at that front, and that's where we live. So as scientists living at the front line, we therefore have to find ways to, you know, deal with issues as they are and adapt a lot of strategies. And also, as someone from the same continent in this particular forum, I would like to provide the African perspective to One Health. So I'll give you experiential points that will help to guide discussions. Recently in February, I was in Abidjan to attend a meeting for the West African Health Organization. It was a meeting that was geared towards developing and validating a 5-year strategic plan for the region, that's West Africa. And incidentally, One Health was a component of that plan that's moving forward 5 years from now. So One Health was within the document. And earlier in 2012, there was a meeting where animal scientists from across the continent, South, East, West, North Africa, all went to Ghana. I was in that meeting. And they were presenting reports for surveillance report for their respective countries for animal diseases. So transboundary animal diseases, the meeting was called Recipe. It was sponsored by FAO, AFRICOM, FAS, USAID. So at the end of the day, certain problems became very obvious in that meeting. The animal health people were organized like to monitor all these diseases and bring reports on a yearly basis. They even had a software where they could report any emerging infection, animal disease. It's called Impress, developed by the FAO. On the other hand, the human side of things, we don't have any such software that is used in a coordinated manner like the Impress. But then they had lapses. For example, collecting samples and preserving them from animals and doing detections in the lab. That was a very big problem. So some of the countries relied on syndromic surveillance to report on diseases. No laboratory testings were done. So, and in the same countries where they had poor animal health laboratory facilities, they are very strong human health laboratory facilities. So it was more like, you know, bridging the gap, ensuring that, you know, where the other group is weak, you can strengthen, and where the other one is weak, you can strengthen. This is the idea of the One Health concept. And because of this, you know, of course, we have software that can report diseases, but we need to think along this line, moving into the future. If we had something like that for Ebola, for example, it could have helped a lot, because when you know about an outbreak early enough, it helps to make the response very quick. And I proposed a software which I have used for surveillance in that meeting. It's called Ushahidi. It's developed by Kenyans. It's from Africa. And we can use it to solve African problems. Kenyans use it to report when they had a crisis in 2007. So these are election crises. So they use it. It's a crowdsourcing software. So this software, you can sync it with, there's a mobile application software called Frontline SMS. We can send messages in bulk and receive messages in bulk. And it works with this Ushahidi, which is something that can present the report in a geographical way, so that you can geolocate where the cases are coming from. So this is a very good software for surveillance. And if we can build on something like that for the human side, that would be good. Also in Accra recently, that was last year in 2000, most of the good things happen in Accra. That's how we normally go. So in Accra again in 2014, there was a meeting on human-centered security. That's it's more like a security something. What are the problems in Africa? You know, there are a lot of terrorists and everything. So they brought all the specialists on security to come and brainstorm and find a way forward and just share ideas. I was there from the human health component, you know, to provide insight on health security. And among the people that were on that panel roundtable like this, at the end of the day, the One Health agenda was also pushed forward. And there was a recognition of the fact that we have a lot of emerging diseases, and that Africa happens to be a hotspot. And so the idea of collaborating to deal with this kind of diseases was also pointed out there. I'll now take a step back and go now to my country, Sierra Leone, where I came from. I can't discuss all of these things without giving you some things from Sierra Leone. I'll give you some figures which you may not believe, because you don't think it's like that, but that's the way it is. So we have a population of about 6 million people. We do have up to 500 physicians. So on record, we have 0.2 physicians per 10,000 people, population of 10,000, not up to, that's the statistic, 0.2. And just say we have up to 500, we have over 6 million people. So it's really serious. We have, in the case of the animal health sector, we have less than 20 veterinarians to treat animals, less than 20, and about 40 livestock officers. And we have more than animal population of more than 10 million. And these are just the facts as they are. And of course, we recognize that we get diseases from animals. And but the animals are not taken care of as they should. So there's a tendency for a lot of infections to go to the other side. And with the work that we've done, there has been a lot of collaboration between my group and animal health scientists locally and internationally. Some of the few examples, you know, we set up an infectious disease lab in Bo, in the second city, Bo, in Sierra Leone. And it's a lab with these molecular diagnostic tools with ability to do, we developed the map of Bo from scratch using participatory GIS, and we use that now to report diseases. We overlay them on top of the map which we created. And so we set up that kind of system. But when we set out with all of these tools, the first thing that we investigated locally was an outbreak in a poultry farm. We had to collect the samples, put them on FTA cards, and run them, you know. And by that we tested whether the kit that we had for use on human diseases could work. You understand? Like using freeze-dried reagents, for example, preparing freeze-dried reagents, say from here, taking them to Africa, and using them in the lab. Do they really work? Are there issues with those? Like putting samples on FTA cards, how long will they take on those cards? Are they actually good for that kind of purpose? So that kind of test we did with the animal outbreak, and we interestingly got some interesting results from the poultry farm that we collected samples from. We had like penicillin-resistant Staphylococcus aureus from the poultry. You know, we use resequencing pathogen microarray and real-time PCR. So when we set up this, that's what we did. A lot of my work you could find on my ResearchGate profile. There are quite a lot. We also, after the conference in Ghana, in Accra, where we met with these animal scientists. So going back home, because the person that represented my country did a poor job, so I was forced to actually go to the animal department, the office there, and we forged a collaboration and started working on monitoring these diseases. So we are able to publish a paper on PPR in one of the districts in Sierra Leone. We have also worked on other animal diseases in the country. So I'll stop here for now. I will look forward to interesting conversations. Thank you.
So for those that are new to One Health, hopefully by now you'll appreciate that what we're talking about are new pathogens and emerging problems. And we can anticipate over the next sort of 8 to 10 years that there'll be yet more pathogens coming into the human arena. And these pathogens don't come from bars, they come from animals. So by understanding, if you want to understand the disease, you have to understand the epidemiology of infections in animals, whether they're wild or domesticated, and how they spill over to the human population, or at least that's the way we're thinking. I want to come at this from a slightly different perspective and think about how to control not only new and emerging diseases, but a whole packet of diseases, vector-borne diseases. And what do I mean by vector-borne diseases? These are diseases transmitted by insects or ticks, bugs, for those that are not used to the lingo. This is a remarkable set of infectious diseases which are highly efficient. Pathogens hitch a ride on a vector because it enables them to be transmitted far more efficiently, because the vector will go from person to person. And we've just done these maps for the world where we've overlaid diseases which are transmitted by vectors. And what I really just want to show you is that there are lots of places where vector-borne diseases overlap. 82% of the global population live in areas at risk from vector-borne diseases. So these are a pretty serious group of infectious diseases, some of them occurring epidemic. And at the moment, vector control, hitting the bugs, is a major way in which we control these diseases. Here are some of the diseases which are zoonotic, that come from animal reservoirs. Yellow fever, dengue, which is growing important, West Nile virus, Zika virus. Just been told there's an epidemic of Zika. I hadn't heard of Zika virus before. In Ecuador, with 18,000 people infected. So this is something which will increase its global spread in the future. Now, to understand these parasites, these pathogens, it's this complex web of vector, pathogen, animal populations, human populations, all existing in the environment. And what I mean by environment, I'm not sure that everyone agrees with this, but for me the environment is both the natural and social environment together. They're inextricably linked. And as an ecologist, I think if you really want to understand the way that diseases are moved and to control them, you have to understand that web. And yet our health systems are set up with a far more simpler perspective, where any good medicine will be a vaccine or a drug, or spraying insecticide on the wall, because we want a simple answer to a complex problem. I take a different perspective. I'm going to talk to you to illustrate this problem with this disease I spend most of my time doing is malaria control. So it's a little creature, protozoan. There are 5 species in humans, one of which is zoonotic. It's from primates. They're almost entirely infections of people, and it's transmitted by this very beautiful mosquito which has been helping me pay the rent for the last 30 years. So the good news is that here we are, where we made great inroads into malaria control in Africa over the last 10, 15 years. It's caught me by surprise, but using 2 weapons, insecticide on mosquito nets or spraying insecticide on the walls. This has been an extraordinary success. We've reduced malaria deaths in the continent by over half. 700 million cases of malaria, we reckon, have been prevented by bed nets alone. And I'm very happy about that, because I was one of the group of scientists that showed that bed nets were protective 30 years ago. But we still got a lot of cases, a long way to go, and still a lot of deaths. Now, what about the bad news? I actually showed this in my professorial inaugural lecture. I can't remember how long ago that was, 15 years ago. The joke is that except if you live in Georgia. But, but the point is, out there are bugs that are resistant to whatever chemical you're throwing at them. And in the malaria sphere, we have a wonderfully effective anti-malaria called artemisinin. We've got a very safe insecticide we put on bed nets called pyrethroids, and there are other things we spray on the walls as well. This is a graph which gives you a feel for one of the problems that we're facing in Southeast Asia. This is the drug clearance rates from Thailand of a susceptible population when you treat patients with artemisinins, and the parasites go within 48 hours. That's great, because most people die from severe malaria within 48 hours of developing symptoms. So anything that brings down parasitemia quickly will be a godsend for dealing with severe malaria. But, as you can see here, in these parasites in Cambodia, taking longer to clear, and these resistant parasites are spreading throughout Southeast Asia. So the point is, and we've seen this before, drug resistance spreads. What's going on within the insecticides we're using for dunking on our nets? Well, the red areas show where we've got resistance. In actual fact, today, there is no place in the whole of Africa where you've got totally susceptible mosquitoes. You've got various levels of resistance. Here's a worst case scenario from Tiastel in Côte d'Ivoire, where what we do is we stick mosquitoes in tubes and see how many of them die. Because the tubes are impregnated with insecticide. It should kill them all if they're susceptible. So anything below this line is resistance. And we've only got 4 types of insecticide that we use for control of mosquitoes. So what this is showing you is in Tiastel, you've got resistance to all 4 classes. So short of throwing an aerosol at them, we're struggling to think of how to control them. The other thing which is a big problem is the human factor. We always have to have fashions. And fashions last 5 to 10 years, and then we've got to do something different. So this is project funding for malaria control, which has been fantastic and allowed us to spread bed nets across the continent, but there is big concern about funding failing. And if this happens, and this is historical data, that these red lines, what these show you are pictures of malaria in different parts of Africa. And the red arrow shows where the program ends. And you don't have to be a genius to see when you stop controlling malaria, well, it comes back. It launches itself back. So we've come so far in the last 10, 15 years of being able to suppress malaria. If we take our foot off the gas now, it could come back and bite us big time. So WHO, taking a broader perspective, like the One Health agenda, recognising that it's complex, what if we could take a broader perspective for control compared to the traditional methods? So let's look at the major problems we've got today. Insecticide resistance, resource constraints. I thought your example of talking about the problems, or the number of doctors per head of population this year and the number of vets is very illustrative of that. The lack of capacity to do infectious disease control. Disease-specific silos. We're all specialists in trypanosomiasis, malaria, and this is what we're comfortable in. So what we're trying to do now is to break down those barriers and look for savings across diseases. The other thing that we all talk about is intersectoral action, and that is really weak. And it goes back to this to our university, not all universities, biology department, anthropology department, but the connectivities are really so important. And yet we've got this traditional barriers to working together. So we do for control. The other big problem is not collecting data on what you're doing. Is what you're doing effective? Is it reducing diseases? So sort of recognising these problems, the WHO came up with this thing called integrated vector management, which has this horrible title, which is the rational decision-making process for the optimal uses of resources for vector control. People would say that what's the alternative to a rational decision-making process, an irrational one? Well, nobody's going to advocate that. So what do they mean by this? Well, it took me a while to work it out. And it might be that you've got one disease that you're going to control, and you use at least two methods. And importantly, the second method may not be in the health sector. So this is what's different. And I can illustrate that later. The other thing that it can be is using one method against two diseases. So in this context, vector control, your bed nets will not only reduce malaria, but lymphatic filariasis, which is a horrible wormy disease transmitted by mosquitoes, will also be attacked. And maybe leishmaniasis as well, dengue, Japanese encephalitis, by putting the same bed net out. Because so much of vector-borne disease transmission occurs in the home. So you're having multiple effects against other diseases. You don't realise that because you're the malaria person, you're the leishmaniasis woman, you're the, so it's taking that much broader perspective. And if we look over time, and One Health will come into this in a minute, in the African situation, when you've got lots of mosquitoes, you've got malaria and lymphatic filariasis around. You drop that, you just end up with malaria. You drop that, you'll have dengue moving. And when you drop dengue, you'll have something else coming along periodically. Chikungunya, Zika virus, and the mosquitoes won't go away. So your infectious disease program changes eventually into a mosquito abatement. Where do we see that? The best example I can give you is in the southern states, because that's exactly what happened there. So that's the long-term vision of where we're going with this. But in the context of One Health and emerging diseases, this is what you're looking for. Always, you're doing surveillance for something new. So where are we with this? Over half of the WHO membership have adopted this policy, but we're scratching our head because there are no clear guidelines on what to do. Some people worry about this because we know that there's only a certain parcel of money. So if you take this broader perspective, you're taking money away from the bed nets. This is a concern to some people. Others people reject it, just ignore it. They sit there with blinkered eyes because we don't do this. We get our insecticides out, and that's what we know about. What you're suggesting is too complicated, and we still want a magic bullet. Anyone here from the Gates? Never mind. The other thing, which I've been shouting for years and years and years, is about capacity building. Because you can't do effective disease control unless you have people that can manage these programs. So these are the sort of problems. So what we've been doing with support from the Gates Foundation for WHO, is try and put some detail onto this. And I'm not going to spend a long time talking to you about this in detail now. I just want to give you a flavour for what integrated vector management is. It will only work if you have the head of state saying it's going to work. There needs to be political commitment. And you have this steering committee set up, where we have the health sector here, but you have a lot of other sectors involved as well: agriculture, finance, environment, education, community, NGOs, anyone that's interested. And these committees work at national level, and they're broken down into smaller levels, into district level, ultimately into district levels or regional levels, depending on the country involved. So the process of what we do is take a long look at the disease situation in your country or your area to assess what's there and to stratify what you're going to do within country. You then have to select what you're going to use. Now, if you go to WHO manuals, they have this shopping list of things. We can use this tool, we can use a fish, we can use an ant, and all these things, and the control program manager thinks, so what am I going to use here? So what we're trying to do here is use interventions that are recommended by systematic reviews, take a more rigorous approach. We do an analysis of the needs and resources, how much it's going to cost, who we need. We implement, we're giving guidance on how to do that, and importantly, you monitor and evaluate. So our mantra is no intervention without evaluation. And this is an adaptive management process. You keep on going round and learning from what you're doing, but you're monitoring and doing surveillance all the time. So that's it in a nutshell. I thought it'd be easier for you to understand if I can give you an example of this. And this is, I've stolen from a friend of mine, Hamuda Kafi from Khartoum. So Hamuda controlled malaria in Khartoum with full support, political support. And this is what he did. He took a very pragmatic review. Malaria vectors breed in surface water. It's an engineering problem, essentially. Malaria is a problem of surface water. So he went around Khartoum and mapped all the breeding sites, or his men did, and women. This one was an old pipe system that was set up by the British, and completely useless now. It's all leaking. In fact, Lucy Tustin's father did put those in. So they mended them, took them away. These things are very familiar to people that have wandered across Africa. When you build a new house, often you need a place to collect the water, to mix the cement, to make the concrete. So you build a house, and then you forget about the pond that you left behind. And these are fantastic breeding sites for malaria mosquitoes. These homegrown malaria mosquitoes. So what Hamuda did was look at the local statutes and said, well, there's a bylaw here, people shouldn't have them. So he sent the boys in and knocked them down. They had campaigns on the fields where all the farmers had to have the fields dry once a week, which meant you do away with the breeding sites. And in fact, he got himself he upset the farmers big time because he fined people that had wet fields when they should be dry. But eventually the farmers came to him and they had conversations and they sorted it all out. So now they work with him. He worked with the schools, 405 schools, 287,000 pupils. They had malaria days where each child went to find a breeding site and either filled it up or treated it. That's a great form of education and an effect. He worked with the Ministry of Public Works. So we're going agriculture here, public works, education. Everyone's involved in this to fill up these breeding sites. It would not be possible without the President telling them it should be done. Very importantly, clearly you know this better than I do, about the importance of telling the community what to do working with the community. There are children here that are doing dramas on this. There are posters all over the place, theatre, short stories, all sorts of things. RBM societies, rollback malaria societies. So everyone here is working to control malaria in the city. And this is the result of their work. Now, of course, if you're an epidemiologist, you say, yeah, that's great. What's the control? There is no control. In this case, it's a very pragmatic approach to doing away with malaria. And the big problem here is, with a successful operation, how do you keep that up? But it just goes to show, well, I haven't talked about insecticides. That doesn't mean I'm not an advocate of insecticides, but in this particular situation, Amuda did that alone. He also runs training schools where he trains people in integrated vector management, and I think he produces about 100 a year. He is a real star. He did it himself. So this shows you what's possible, and the cost of this, 10 cents per person per year. So, and you asked me questions about what possibilities does this paradigm create for researchers working with and beyond the social sciences? Everyone gets involved in this, all sorts of people. I put in red the types of flavours of researchers that are involved with my latest research, where I'm interested in housing, improved housing as an intervention against malaria. And this is where we start off. And I'm sort of slightly, rather aggrieved that we talk about integrated research or transdisciplinary research, because I've been doing it for 30 years. And I'm still surprised that we're having this conversation. It's the most natural thing in the world to do. If you want to assess risk of transmission, you have to examine it from a human perspective. And my own interest is in controlling vector-borne diseases. If you want to control vector-borne diseases, it's utterly essential that you understand what the community are doing and get them on board to help you with that. So it's all sorts of disciplines that one needs. Second question you asked, what are the pitfalls and blind spots that this collaborative agenda might entail? Theoretically, many oppose this rather complex approach. It can appear wishy-washy, and indeed we're still defining what should be done. And it's a work very much in progress. I actually believe very strongly in when you don't know the answers to things, go and speak to some mathematicians, modelers. And I've just come back from Washington, where I spent 2.5 days talking with mathematical modelers, thinking about these issues. What combination of interventions will work best? What will be most cost effective in what situation? To help sort of guide this sort of thinking. So, and then you actually go out and do it and see whether the mathematical models are right or not. Researchers from different areas have to work together. I think one of my frustrations is that what you don't want in a project is the anthropologists to go and do their study and not talk to anyone and publish their papers in one journal, the vector biologists to do the same and not integrate. This really requires people to sit around the table and discuss the whole thing. And I think for the future, and I think the really difficult problem is getting publications where you've got all these components in the same paper that you're sending out. And it's also difficult to get funding for these multidisciplinary approaches, to get them through our current, for me, for the current research organisations in this country. This sounds obvious, but everyone must understand what the others want. Pragmatic approaches to disease control or understand risk factors. Keep to task, don't wander off. Oh, isn't that interesting? We'll go there. So, in this short summary of integrated vector management, it's a broad approach to vector control. I think the most essential element is that it's using multiple tools. I didn't say, but I should say now that it includes drugs and vaccines as well, but also thinking outside the health sector to get everyone on board. And my example is with malaria control. In East Africa, we used to have engineers, malaria engineers, that worked alongside malaria control. They don't exist anymore, and that's just bizarre. And to make decisions based on the evidence from the field. And it involves working with everyone, from the community to the politicians. These are big problems. They need full engagement. Okay, that's all I want to say.
Can I invite the speakers? Thank you.
Well, I just want to start first thanking everyone. It's fantastic. But just picking up or kind of parasailing on Steve's last couple slides about kind of what it means to be doing One Health. Because it's clear from the three presentations that One Health as a concept and approach to kind of tropical disease is nothing new. Right? This is a very classic kind of approach from thinking Berkshire to, sleeping sickness. And I'm wondering a bit more about this current approach, which is clearly on agendas about human security, about, that it is being brought forward as an agenda in some places. What does it mean? How has it changed the kind of ways that you approach problems? Has it made any impact in terms of not only who you collaborate with? Because I think when we think of One Health, it usually has to do, in my mind, one thinks of this is interdisciplinarity. But has it changed the kinds of approaches that we think are good? Moving from eradication, are we now focused on surveillance? Is it about prevention? What are the kind of tools of One Health that would that exemplify that kind of approach? Or what are the new opportunities? Oof.
I think there are quite a lot of structural things that need to be put in place to make it work better. From the One Health examples that I've been exposed to, there is a risk, as you alluded to, that people fall back into their disciplines, and that everyone says they're working together, but in fact they follow their own agenda, and somebody needs to keep somebody to task on that. For me in Uganda, it's really relatively straightforward because of of COP2. That is a One Health body. Now, what we would like to do with COP2 is actually get them to get more engagement from anthropologists in country and to strengthen their teams. And they will do that, and they are doing that. They are adopting that approach. There's also some suspicion between medical and veterinary activities in the field, and because of the allowances situation. Jakob Zinstag makes this very nice example all the time of vets and medics going out and sharing one vehicle and going to a community and doing something. But if you're not paid very much money in the community and sharing transport or sharing that is going to mean your household income is going to be halved because half the number of field days are available, and that's how you're making most of your money. That's a problem. So there are all sorts of problems that you wouldn't necessarily think about that actually act as disincentives to collaborate. And I think it's quite easy to come in from a sort of sometimes European perspective and say, well, why don't you just do that? And there are very good reasons why things are done the way that they're done. They might not be the most efficient, but there might be an underlying reason which is actually quite critical for that system to work. One of the best scenarios that I have come across for surveillance are the field epidemiology training programs, some of them in Asia, where young people learn and train together from both the veterinary and from the human public health side, and they do outbreak investigation together. But it depends what you're talking about with One Health. outbreak investigation usually involves some sort of government response and some sort of active response. And in some circumstances, as we've seen with Ebola, it's less problematic because everybody rallies together and does something about it. It's when you're talking about these endemic scenarios, these endemic conditions that are not going to be solved in 3 years. We know that we need 5, 10, 15 years of constant pressure to suppress some of these populations. And there's no money at the front end to do that. Then it becomes a much more difficult space to negotiate. You know, if someone said, oh, well, we'll put 15 years money up, then I think more people would collaborate and sectors would cooperate. But while everyone's looking for short-term funding and short-term solution, there is a struggle for resource.
I think I agree absolutely what you say. I think one of the critical elements is career structure, so which works at all levels for program managers in the field that can see that all up the scale that there's, if they stay in their post, they will go up the career ladder. There is a pathway for One Health, training One Health. It boils down to PhD students that we're training in multidisciplinary, across disciplines, which is great. And you have a student that's got these talents. Is where are they going to go in the future? Are they going to get a job with those talents? I think the REF system is counter to transdisciplinary research, because where do you publish your work where do you publish your transdisciplinary work? In journals which are low impact, and we're going, and you are assessed, one is assessed as a scientist by where you publish. And so, so on one hand, people are encouraging scientists to be transdisciplinary, but the metrics we use for assessing someone's quality doesn't match. And it's also an issue when it comes to transdisciplinary grant proposals, because if I can just try and give you a shorter example, let's say it's partly anthropology, partly vector control. So the proposal gets sent out. The anthropologist loves the anthropology, doesn't understand the vector side of things, so it would tend to dampen down their score. And similarly, the vector biologist loves the vector biology, doesn't understand the anthropology, dampen down the score. It's a natural thing to do, to be conservative with your scoring. So the scoring levels for proposals in transdisciplinary research tend to be less. And so I have to get desk officers and put my arm around them and say, there, it'll be all right. You'll just have to explain this to people, because they're worried about funding projects at sort of lower scores that they would ideally like to do. And I think that has to be sorted out as well.
Well, look at it from a different viewpoint, the One Health approach. When you look at animals in the wild, domestic, and then humans. So for many of the diseases, let's say they start in the wild, they get amplified within the domestic, eventually going on to humans, like we saw with the cycle for plague. And so if we have this join-up approach, we may be able to easily detect the diseases when they are in the early part, so that those other organisms will be like indicators that something's about to come our way, And concerning funding and integrating our efforts in the field, from the African perspective, because that's why I'm here representing more or less, resources are not much, so we have to improvise most of the time. So we do what we call frugal science. Frugal science means you do much with little, but you still make much impact with little. Like I was telling you about Ushahidi, it's open source. You don't pay for it. Install it, it's all free. Frontline SMA is free. We can do quite a lot without spending $1. if you have the skills, you know. And the Germans have a better way of integrating researchers. I've observed with the DFG, for example, I've seen many research groups with the DFG where you have this kind of One Health groupings and they support them easily. So if UK and America could follow suit, that would be very great.
I mean, it depends what you're looking at. It depends what you want One Health for. One Health is an enormous beast, but in most of the examples that we've seen today, where actually One Health is a solution for broken public health.
Mm-hmm.
If public health wasn't broken in most of these scenarios, then would you need one?
Well, I wanted to ask you too about, I mean, you started your talk very interestingly with fear, right, as a driver, as a key kind of component in pushing the agenda, the fear of contagion, and how that, I mean, that produces a set of kinds of approaches, right, in terms of viral hunting or predictive look, which is about also protecting, you know, diseases from coming to us, right? Which is how much of how the Ebola outbreak was framed. It was, you know, here's something that might keep over those borders. And I was wondering about that kind of balance in One Health of, you know, fear of contagion or emergence, and I mean, these kind of endemic problems that.
I mean, I think that drives a lot of the large-scale funding, undoubtedly. But I think that on the other side, a lot of the emergent One Health programs that are coming out of Africa and Asia aren't necessarily dependent on large-scale funding like that, and they are coming up from within, and it's where those two are going to meet in the middle that I think is going to be the most interesting. I mean, certainly WHO, FAO, and OIE in Mexico, you know, they said, oh, we'll have rabies and we'll have multiple drug-resistant, you know, antibiotic failures, and I think avian AI was their other sort of priority. And yet, you know, then we hear about these other much more pragmatic approaches, which could have much more impact. You know, when you're actually, I mean, the reason the Stamp Out Sleeping Sickness program worked so well wasn't because of taxi flies at all. I mean, you'd never see a taxi fly in the wild in Uganda unless you put a trap out. They're not bothering you. But the reason that the farmers want to adopt an insecticide approach is for the ticks. That's the driver for the adoption of the technology. It's nothing to do. So if you'd gone into those communities on a sleeping sickness ticket, you would never have had adoption of that technology because there was no point. The point is that these animals are free of ticks, and it's the ticks that sort of drive the whole program. So, you know, I think this integrated control is definitely the way to go for most of these, and most owners are looking for more bang for their buck. I think the problem that we have is that they don't actually want to put the buck down for long enough to realise those results. So there's a reluctance either because of government time and period in office that they can't make promises into the next administration. But without that security of funding, I think that most of these programmes, whether they're One Health or whether they're linear, will ultimately fail.
I think that one of the difficulties has been with neglected tropical diseases. You know, that N in NTDs is vital. It's quite appalling how little money is being invested into basic research in many of these diseases. And I think that's changing. It's changing slowly. I think, you know, if you look back over the last 10 years and compare what's been spent on that research on the 10 years previously, it hasn't improved, but a lot more needs to be done. So this is work in progress.
I mean, if you have a look at the tremendous successes that have in public health, the smoking bans, you know, and the amount of money and the amount of energy that's been put into that for you know, actually benefits that are not incomparable with the benefits that we're talking about here, and the commitments and the political commitments. You know, it's a very large contrast.
I mean, what changed it all in malaria control was the economic analysis, that if you controlled malaria in Africa, you would increase development and economies would increase by this. So for a relatively small amount of money, you would get large payments back in new markets.
And are you?
Yeah, I mean, that's GDP of 6% overall. It's, African countries are barely touched by world recession. I mean, clearly there's a long way to go and there's great inequalities throughout, but I mean, for me, I was brought up with books, Africa in Chaos, you know, for Volume 1, Volume 2, and there's still a lot wrong, but there is extraordinary development going across the country, exemplified by the changes in housing stock. You know, 25 years ago, thatched housing was everywhere. Now metal roof houses are dominating. Quality of housing is improving. Rwanda, they don't have any thatched houses anymore.
Actually, that brings up something interesting, because there's some work, at least done in New Guinea, arguing that there are some issues with metal roofed houses in regard to social interaction in heavy rainfall areas. There's a whole bunch of other things. The reason I bring that up is my one concern with the One Health, and I've been involved in a number of One Health programs, is this sort of biomedical model as core. That is this sort of, there's medical doctors, public health officials, and veterinary sort of doctors as the sort of central force there. Steve, your sort of outline had a more integrative sort of diverse group. But it has concerned me, because a lot of the large One Health funded projects I've seen don't have much anthropological input and don't have much sort of engagement. I mean, they take, as you said, pathogens come from animals as a sort of the baseline, and you followed that up a little bit later, but pathogens can come from animals, but pathogens from animals are risky due to human activity and ecology, which is both material and perceptual, right? So the way in which people experience their health in their local environments can have huge impacts on these kinds of systems, and many of the One Health programs that I've seen don't really take a lot of those local perceptions and engagements on board as much as they could.
I think the critical factor there is the lack of that capacity in a lot of the countries that we're working in. Most of the countries have got vets and public health officials. Very few of the countries that I've been attempting to do One Health in have really strong social science faculties. It's a shame.
But what you alluded to is the structure, the high priesthood within health science.
Right. Yeah.
And the papacy.
And
who's
the way,
at the top.
the direction of who's really running, whose say counts more.
Yeah. Well, this is where vector biologists and anthropologists,
Yeah.
why we get on so well, isn't it? Because we recognise clearly that we're at the bottom of the
Nobody loves us. And the medics don't like us, and the vets don't like us.
and actually, I think of it
Got no mates.
partly that is our own fault, because you give us a beer and we tell you the most extraordinary stories and nobody can take us seriously.
I'm not so sure that it's an issue that it's a country incapacity that, you know, maybe there aren't social scientists. I mean, one of my experiences is being involved in a One Health project with a neglected disease. The high priesthood was in fact the biomedical researchers. It wasn't molecular biologists, and I think that if you're really going to do it, you need to sit down and rework what the question is. The question is not the epidemiologist's question. The question might be another one that comes from the interactions of an anthropologist or some kind of social scientist. But I guess another issue might be how you understand the so-called local populations and where they can contribute. This is not just a question of getting these local populations to comply with the problem that we have identified, and we're going to, roll out all of these interventions, but actually having some kind of interaction between the people who are living with this illness and what they think is going on, and how that might actually change the question that you're asking. and the kinds of scientific knowledge that are produced from it. And that's where I saw a huge amount of resistance, that people had their own ideas about where this particular disease was coming from and what had precipitated it, what kinds of interactions had provoked it. And the epidemiologists on the project didn't really want to hear about
Yeah.
it, even though they were very happy to parade
That's a very
the
good
One
point,
Health.
but how many public health bodies across Africa and veterinary bodies actually have anthropologists on staff?
Oh, they should, though. I mean,
They should,
that's
but,
the whole
but
push,
very
right?
few do. Very few. In my experience, very few do. So when you engage in a project in country, there's no anthropologists to be put up for that service. So they either have to go to the university and then negotiate, time out from the university. But there aren't any core on staff, and I think it's a big gap. I mean, you're right, and it's a big
not
problem.
But it's not just a capacity issue, it's also, or maybe it's connected,
Well,
but
it is
it's
a
also
capacity
about,
issue.
but an openness to rethinking how you go about doing what you're doing. And whether you're willing actually to change the question that you're asking because somebody locally says, no, this isn't transmitted in the river, it's transmitted someplace else.
No, I don't agree with that. I don't think that there is a reluctance to it. I think that there is that field or that area needs to take its place. No one's going to give it its place. It needs to take its place, and that place needs to be taken in country.
But
So One Health then isn't a transformative project. It's an idea that
It's
new
a
way to
project in
implement
transformation. I mean, I think it's very early. It's extremely early. I mean, some people think that One Health is just getting vets and medics to go out together to the field. That's some people's perception of One Health.
There's actually the official, if you go to the One Health page, that's actually what it says.
Yeah, I mean, it depends who you ask. I mean, of course it's not it. I mean, if you look at the failures in the rabies programs, if you look at the failures in a lot of the control programs, if you don't actually have people on the ground actually telling them how it's going to be, they're never going to work. And I think most public health interventions accept that. But there is a lack of capacity. I don't agree. I mean, I've been working for 30 years in this area, in the field, and there is a lack of capacity. Where are the social anthropologists in country?
So
They're hidden,
I'm not denying that, but I also think that there are other things going on.
I think
what we normally suggest is that Africa is resource poor. We know that. Some of us have a different viewpoint. We don't accept that resource poverty as a disadvantage in a sense. But the reality is the continent is resource poor in terms of intellectual. So we've always encouraged people that go to Africa to do research, to relate to the universities and strengthen their areas of research. So if you're an anthropologist and you go to Africa in any country, relate to the university there, see how best you can strengthen that sector within the continent. Then that way you leave a footprint behind that can continue. Because frankly, like in my country, we don't consider anthropology as a very important something. We have people being trained in anthropology. So how would you get one when they are not being trained?
Yeah, I agree with that.
So when you create, the awareness, let people see that this is valuable, then obviously they'll follow the trend.
And that takes a long-term institutional engagement.
Take time, but we'll get there somehow.
I don't think that capacity is just about its sort of perpetual, forever absence or presence in particular places. But of course, people are moving. People are very mobile. They're moving around. They're moving for contracts, and as well as this kind of what is very laudable and important, which is the idea of continuous investment, or people who are working in particular countries interacting with institutions to improve and build their capacity. We also need to be responsible in putting together these programs by not distorting in-country capacity, by pulling people away to do different things, by getting people who are in fact very highly trained to work on extremely short-term contracts, doing things like collecting data from master's students' theses, right? So there are violations as well as things there are things that that are happening that are bad things, and it's not just not doing the continuous investment. It's about
But it's also coming, what you mentioned, there's the internal capacity, but there's also the training of the medical doctors and the vets that go in there to be able to understand that in one place, sleeping sickness can be caused by the fly and the cycle, but it can also be caused by witchcraft. And both of those things are real for the people experiencing them, and how you deal with that and how you engage with that without necessarily deprioritizing local beliefs in those kinds of contexts. Because a lot of the groups that I've worked with just go in and say, oh, well, these people don't know what's going on. And that right away creates a block to that kind of engagement. So the anthropologists can also play a role training the doctors and the vets and the other people on these programs.
I think that's where the kind of long-term engagement with institutions is really important. I've worked for 10 years with the University of Cape Coast in Ghana, and I think that's, so working with training PhD students, postdocs over a long period of time, and I think that's also the way of getting away from, of moving the place within anthropology. So it's not just the Mickey Mouse anthropology, so it's not just the anthropology light, it's not just finding out some local people's beliefs so that you can talk to them in their own language and change it. So that the kind of anthropology you get is a more critical, and I don't think that means it doesn't have to be applied as well, but it's critical. It's the kind of anthropology that we think we're doing on our anthropology, which is often actually really different from a bit of qualitative research that goes on the side, which is really linking to your point that it doesn't actually challenge anything. So it's about people and what they do, but it's more than that anthropology. It's about thinking how that fits in with bigger structures of power. And I think that's the kind of anthropology that often is missing from that. What tends to go in is this kind of anthropology light, which is maybe better than nothing. But it's actually, anthropology has so much more to offer than that. And I think it's through these kinds of longer term partnerships. I don't work anywhere in Africa without working with local universities, because I learn a huge amount, I get a huge amount from doing that, and I think that's...
But it is also our fault for how we present anthropology to non-anthropologists. We basically reduce it to ethnography, and people think that that's what anthropology is all about.
Well, I think we do two things. We either reduce it to ethnography, or we use such long, complicated words and no one else can understand them. And we need to get over that, really.
But I think that's what we think anthropology is.
Yeah.
Kind of an ethnographic description, and that's what we do. It's really imperative that we, make them understand before we can claim we've been misunderstood.
Andy from the back.
It kind of follows on, so it's just that I noticed it with Ebola in some ways. It might be because we're at a workshop about anthropology and ethnography, but so we're talking a lot about it, but you've got the biomedical, the sciences, the doctors, the vets, and the anthropologists, and it's kind of becoming that's what One Health is. And there's all sorts of other kind of social science disciplines. It's interesting that and it happened with Ebola as well, that like everyone suddenly was saying, we need social science and anthropology, no one latched on to anthropology. And there was all sorts of confusions and assumptions and different, and I don't know quite what, different people have very different ideas of what anthropology is and what to do. But it's I guess, something to consider what's happening when everyone gets obsessed with anthropology. And is that the new kind of hierarchy, new hierarchies in social science, or like the people at the papacy?
I'm conscious that we've run quite a bit over, and I know that Sue just went to go check her tab, but I wanted just another last word is I really like this idea, thinking about frugal science, right, as something, if one effort of One Health is this kind of collaborative and sustainable agenda, is the thinking about the kinds of science that one can do and continue to do in a place that isn't built around endless influxes of funding. And frugal science doesn't have to be, bare basics. It can be incredibly innovative. And that, I think one of the themes that's come across these papers is where does the economic fit into One Health, or how do we integrate that kind of perspective into the work that we do? And I think, thinking forward into the future of what research directives are useful, I think kind of frugal science is a very useful kind of paradigm to push forward.
If I could just add
Yes.
on to that. So when we were writing our manual on integrated vector management for Sub-Saharan Africa, it was really difficult to write because on the one hand I had an imaginary head of vector control from South Africa with a lot of facilities, a lot of money available, and my friends from the Gambia in the district who was overworked, underpaid, very little resources. So throughout the document we had Moose's tips, which was what could you do, what's the minimum you can do,
Yeah.
but also I take the point, the innovative ideas as well. But I think crystallising out the essentials is really important.
Yeah.
And if I could add, I think the thing that excites me about One Health, and that I see in these relatively research is that it's experimental. Is that it's not applying anthropology, entomology, public health, and epidemiology to the problem, but that there's a way in which it's actually setting up open experiments, and that doesn't pay off, but like there's a little bit of wandering off, I guess, that does pay off, right? And so I think that's what I think we can think about is that it transforms us as anthropologists. It doesn't make us stop being anthropologists, but I think it also can potentially transform how you do veterinary medicine than I would imagine the other fields. If it's thought of less as a problem-solving application and more as an experiment.
So in anthropology, are you guys familiar with adaptive management?
Yeah.
So, okay, so
Yes, in ecological conservation.
yeah, sure.
The thing.
Yeah.
That's what I guess we're trying to introduce into this.
Flexible engagement.
Yeah. Great. I think we should probably end there because we're over.